Good morning. And first of all, I would like to apologize for not being with you today. It's the first time that I do not participate to the Alessandro Lupoli Day. And it is because of surgical reasons. I was recently ill and now I'm much better, of course. And it's a pleasure for me to talk with you, as usual, about autoimmune diseases and to discuss with you the causes and prophylaxis of infections in this large number of diseases that we know for many years now. Here are my conflicts of interest. It is some consultancies for different companies. And I would like to discuss with you, first of all, the infections in autoimmune diseases, the influence of treatments in the occurrence of infections, what are the prophylactic measures we should apply, some words about vaccination, and of course, some words also on COVID-19, which is really a major concern for us. I will start with polyarteritis nodosa. Here it is the first slide showing this disease with renal insufficiency. And this poor guy died, of course, of the vasculitis. It was in the 19th century. But when you look at these very severe diseases, you can see that when patients are not treated, they die of the disease and very quickly. This paper is not very old, 1979, and shows that at that time, some people have not been treated and only 13% of them are alive. When you treat patients with vasculitis with steroids alone, the survival is not very good. And it is when immunosuppressants have been introduced in refractory patients and after in new patients that the combination of immunosuppressive and steroids improved survival. But there is a price. And here it is a more recent series coming from our group, showing that when you look at the survival rate, comparing here steroids to cyclophosphamide, you see that the first cause of death are probably the vasculitis. After that, patients die from other causes, and infections are a part of these causes. And in the long term, it is mainly vascular manifestation and sometimes also infectious manifestations. In fact, infections are present at any time. Initially, when you treat with a lot of steroids and immunosuppressants, and now rituximab, and after that, the consequence of the immunosuppression in general is a long-lasting, and sometimes years after. And we see that now when we treat patients with rituximab and some other biotherapies. But there is an improvement of survival, and we cure the majority of our patients. An improvement of survival is certainly the consequence of the optimization of therapeutic strategies and of minimization of treatments. In the past, we treat with a lot of steroids, with a lot of immunosuppressants, and now we give less than in the past. Morbidity is also a major issue, and prophylactic measures should be taken to take care and prevent morbidity. And there is some comorbidities like diabetes, age, nutrition status, and so on, that we have to take in consideration when we treat our patients. The infections are responsible for the morbidity and mortality. They occur mainly during the acute period of the disease, as I showed on the vasculitis slide. But they occur also in the long term as a consequence of the prolonged immunosuppression. It was the case with methotrexate, azathioprine, mycophenolate mofetil. And since rituximab is largely used in autoimmune diseases, patients are at risk of infections and sometimes several years after stopping rituximab. I have some patients with vasculitis which have 2 grams gamma globulin 10 years after receiving 5 infusions of 500 milligram rituximab. When you look on this slide, the infection in the long term, you can see that there is, of course, different causes of infections, but the lung is certainly one of the major causes. And there is other infection, viruses, different systemic organ infection, kidney infection, and so on, but the lung is certainly one of the most frequent. In this series of GPA, with 35 patients and 91 infections, you see that we have the lung, which is the first cause, 34, and after some skin infections, including shingle, virus infections, urinary tract infections, and more rarely bone and joints infections, as well as gastrointestinal. The risk is early. Most infections occur during the first 3 years of treatment, and for most of them during the first year of treatment. And when we go in detail, it is a dose of cyclophosphamide when we treated with cyclophosphamide, which was one of the major causes of infections. Up than 3 grams of cyclophosphamide per month was certainly inducing a lot of complications. This paper comes from the German group, and when you look at the cause of death and all other side effects occurring during the GPA patients they have treated, a lot of patients, 445. In the 60s, you had few malignancies, less now, but not significant. Myelodysplasia, which has regressed all over the time. Cystitis due to cyclophosphamide, which has considerably regressed because we'll treat with less cyclophosphamide first, and with pulse cyclophosphamide and not oral treatment like it was in the past. But when you have a look at infections, there is approximately the same number of infections, around 20%. In this other series of patients, and it is a cause of death, you see that infections is the first cause of death. And if you combine, and when you give the detail, it is septicemia, lung infections, and so on. And some rare infections, but you are not surprised with that. Everybody sees very rarely endocarditis or mycobacteria, things all the time to mycobacteria occurring during treatment. Here it is SLE. It is the Cervera cohort, and like with the German groups, they have compared the patients at different periods of time, and you can see that infections also are very frequent, and between 20 and 30%, which is not neglectable. There is also some rare causes, but you see that lung infections is also very frequent. I would like to show you some example. For instance, this one. Here you think to aspergillosis, of course. In fact, it was not aspergillosis, it was GPA. But when you have some image like that, you have to think that to aspergillosis and to look at this fungus. This one, this poor patient lost the vision because she had cytomegalovirus retinitis. Here it is more frequent, tuberculosis, and but you can have also pneumocystis, gyrobacillus pneumonia, and some fungal infection. And more rarely, leukoencephalomyelitis have been described in patients who receive cyclophosphamide. It is not the consequence of the disease itself. It is a consequence of the immunosuppression. It has been cited with rituximab. Personally, I have not seen any case of rituximab inducing leukoencephalomyelitis, but it has been described. But I have seen some patients who have received cyclophosphamide. And it is also another indicator that we should try to treat patients with less immunosuppressant than in the past. Here you have in systemic sclerosis, it is a natural history of this systemic sclerosis. You have pins, and this fibrosis is, of course, a source of many infections. When a patient has, for instance, a pneumonia, any germ, the patient can die because the underlying lung status is very, very severe. And here it is also an example of the GC virus in GPA. And on the back slide, you see that the autopsy showing this virus. How to minimize the risk of infection? The impact of the new strategies based on the result of prospective trial is essential. We have to reduce the duration of induction therapy. And the first step was certainly when we treated with cyclophosphamide to use pulse better than oral treatment. And also all other measures like prophylaxis and the duration of treatment. This slide is quite an old one, but very interesting. It is in systemic lupus. And you see that when you treat with a very low dose prednisone, there is less side effect, infectious side effect, than when you treat with high dose. And even with very, very low dose, 5 milligrams is not nothing. Of course, sometimes 5 milligrams is acceptable because you have asthma or other arthralgias and so on, and you have to keep your patient with 5 milligrams, but 5 milligrams is not 0 milligram. And the risk of infections and other side effect is present. In the urolupus nephritis trial, the occurrence of infection, here it is the comparison of high dose scheme of cyclophosphamide and low dose, which is 500 milligrams 6 times, 3 grams only. And you see that when you use 3 grams compared to the NIH protocol, you divide the severe infection risk by 2. And the number of episodes also is divided nearly by 2.5. When we treated, when it has been applied to vasculitis, here it is a UVAS trial comparing oral to pulse cyclophosphamide, and with a scheme minimizing and decreasing progressively prednisone dose, you can see that the risk of infection is also divided by 2, 6 versus 3. And at the same time, the number of remission and the number of relapse is not significantly different between both groups. Another point here is the same study, 5 infection in the oral treatment versus 1 in the pulse treatment. And when you look at the survival rate, it is exactly the same. In elderly patients, we have to make something more because it is a population of risk. In this study, we did with we studied patients over 65. Now we have the same study over 75 because 65 is not very old now, and but the results are comparable. We compare 2 arms, a conventional treatment to a treatment with less cyclophosphamide. The treatment with less cyclophosphamide was only 500 milligrams per infusion and not adapted to the surface of the body. And we divided also the duration and dose of steroids. For instance, in the first arm, it was 8 grams during all treatment. And in the other one, a shorter duration, lower cumulative dose, and the lighter arm, it was only 5 grams steroids. And when you have here the comparison, 8 grams, 5 grams, and when you look at the end, the survival without side effects, you see that the survival is much better when you have treated patients with less steroids and less cyclophosphamide than with higher dose. And the difference is significant. In the RIFT trial, you know this trial. It is a trial on rituximab compared to cyclophosphamide. The first part was analysis at 6 months, rituximab in one arm, corticosteroids and cyclophosphamide in the other arm, placebo after rituximab in one arm, and azathioprine after cyclophosphamide and steroids in the other arm. The primary endpoint showed that the results were quite comparable. It is a non-inferiority trial. Rituximab is not superior, it is non-inferior, which makes a difference. And the secondary endpoint was the same objective, but the patients were kept under low-dose corticosteroids, less than 10 milligrams. You see that the results are quite good and comparable in both groups. The adverse events, you had approximately the same number of side effects between both groups. But what this study showed, not at 6 months, but at 18 months, is that some patients relapse less than others. And those treated when they had anti-MPO antibodies relapse less than the patients who have been treated with anti-PR3 antibodies. And it is very important because we are at the beginning to individualize a population of patients who relapse more rarely than others, and maybe that this subgroup of patients deserve to be treated with less drug. And if you have a population with less drugs, you will have less side effects. In the RituxVAST trial, which has been published the same week in the same journal, it was a combination of rituximab and cyclophosphamide to induce the treatment. And the results were approximately the same. But what is, in my view, very important is that the patient had a lot of infections and a lot of side effects. And the combination of rituximab and cyclophosphamide is certainly at the origin of this lot of side effects. For maintenance treatment, we proposed to compare rituximab versus azathioprine. It is a main recent trial that you know. And when you look at the results, you see that in this population of 115 patients divided in two groups, you had in the patients treated with azathioprine, 28% of major relapses. In the other group, 5% of major relapses. And it makes a difference because the patients who have relapsed in the azathioprine group, which were a lot, have been retreated with rituximab or with cyclophosphamide or with other drugs. And at the end, not at 18 months, but maybe at 2, 3, 4 years, the mortality was higher in this subgroup of patients. And one of the causes of death could be the gamma globulin level, because with rituximab, you decrease the gamma globulin level. In fact, in medicine treatment, because we use, I think, only 5 milligrams rituximab, there was no difference between the group with azathioprine and the group with rituximab regarding the number of grams of gamma globulin. In fact, rituximab decreased IgM, and at the end, the majority of the patients did not present so many severe infections, bacterial infections or fungal infections. It was quite comparable in both groups. But when you look at the severe adverse events, it was not neglectable. Half of patients had something sometimes very limited, but sometimes much more important. And here it is a detail of the patients receiving rituximab and or azathioprine. And when you look at that, you see that one patient died from septicemia. It was in the azathioprine group. And in the rituximab group, what is significant in my view is the occurrence of pneumocystis jirovecii pneumonia. And when we analyze in deep this protocol 2 years, 5 years after, we have discovered some other pneumocystis jirovecii pneumonia, sometimes long time after stopping rituximab. And for this reason, we recommend to give a prophylaxis with cotrimoxazole. And here it is a number of deaths in follow-up. And the number of pneumocystis jirovecii pneumonia, it's not neglectable in the rituximab arm, 2.6% at the end. Now with a systematic prophylaxis with cotrimoxazole, it has disappeared. In the main reason, when you look at 5 years, you see the difference in survival and survival, overall relapse-free survival, not overall survival, of course. And this overall relapse-free survival shows that in patients treated with azathioprine, they relapse a lot, but they relapse also, but more rarely, less frequently, in the group receiving rituximab. That's for this reason that we promoted another trial and comparing rituximab on demand, only in case of increase of CD19 or titer of ANCA compared to the conventional treatment of rituximab. And when you look at the end, the patient who receives a fixed dose, which was the main reason protocol, in fact, 5 infusions, 3 only in the other group. And the number of relapses and major relapses was approximately the same, was no significant difference between both groups. And the survival was the same, excellent survival. But what to do with the results? I come back on this slide. The results are the same in both groups. And we said, in fact, it is easier to treat patients long-term with fixed dose. But when you see what happens with COVID, maybe that if you can minimize also the treatment with rituximab, the results could be better. That's some clues for the future. We have to think to that. COVID-19 has been studied in autoimmune diseases. Here it is an Italian cohort of patients. And the patients were studied in Lombardy. And you can see the demography of this population of patients. It was made on questionnaire, which is not perfect, but I think it gives some information. And here it is a treatment that the patients have received. You see that the majority were with hydroxychloroquine, but there is some with methotrexate, belimumab, azathioprine, mycophenolate mofetil, as all the usual treatment proposed in these patients. The reason for hydroxychloroquine discontinuation or reduction are shown here, and the same for immunosuppressants. And when you look also on this slide, here you have the number of patients, the distribution of the patient with polymyalgia rheumatica and systemic vasculitis who had COVID-19 in a general inquiry made all over the developed countries, United States, Europe, and South America, and also in other territories. And this study for me is of very interesting, major interest. Why? Because it is a large cohort of patients, more than 1,000. And you see that when they contracted COVID, half of them were not hospitalized. But 10% were hospitalized and did not receive oxygen. But it was a group and not a negligible group of patients who were ventilated or received oxygen, and the mortality is high. And unfortunately, in my patient, I have also some patients who had COVID, and sometimes they have been vaccinated before, and they had very, very quickly, because they were largely immunocompromised. All of them had received rituximab. They developed the disease and died of the disease. And when you have the combination of elderly patients, immunosuppression, and COVID, patients are really at risk. And the efficacy of vaccine in these patients who have received immunosuppressants, including rituximab, but including also corticosteroids, are really at risk to develop a very, very severe disease. The characteristics of poor outcome for these patients are shown here. The age, in this cohort, the sex, but I don't know if it is really of major interest to see that. The comorbidities, the dose of prednisone, 10 milligrams, and the moderate or high disease activity. In fact, I think that the high disease activity is probably not a major point. The major point is the pressure given by the treatment. What is the prophylaxis that we can propose to our patients? First of all, we have to vaccinate our patients. We have to vaccinate all patients if possible. Here it is a study that was made concomitantly in my center in Cochin, but it was for the H1N1 epidemic, and in Switzerland in the group of Pr Guillevin. And Pr Guillevin has vaccinated patients with rheumatoid arthritis, and we have more vaccinated patients with vasculitis and systemic lupus, Sjögren, and so on. But it was a large cohort of patients, and you can read that in Clinical Experimental Rheumatology. And what we observed is, come back on the slide. What we had observed is that the vaccination was well tolerated, and we do not contraindicate vaccination, that it has been made by some doctors. We think really that we have to vaccinate. The tolerance is good. The vasculitis flare occurred sometimes, but it is not so severe and easily controlled by an increase in steroids, for instance, for a short time. And the same for rheumatoid arthritis. It was, in most patients, very well tolerated. The benefit of vaccination is really higher than the benefit of the other prophylactic measures. What about pneumocystis jirovecii pneumonia? All patients treated with immunosuppressant, and we started this policy when we have treated our patients with cyclophosphamide, should receive cotrimoxazole 400 milligrams per day. Of course, we do not do that for the combination of cotrimoxazole and methotrexate. I know that some doctors do not hesitate to combine the drugs and with a supplementation of folic acid. But I think really that there is a risk to have aplasia, and we really do not recommend to combine methotrexate with cotrimoxazole. But in we have Welvone, which is possible to give to patients taking methotrexate. And we can also change the immunosuppressants and to switch, for instance, methotrexate to azathioprine, which is as effective. But because of that, you will reduce largely the risk of pneumocystis jirovecii pneumonia. There is a minimal residual risk, but it is not really important. 1 or 2 patients without prophylaxis, and you have seen in the main recent trial, after 5 years follow-up, it was 2.6% of patients who have developed this side effect. And one point is very important. Do not stop cotrimoxazole when you stop the immunosuppressant. You have to stop only when immune reconstitution is obtained, which is in fact years after sometimes, or months after, at least 1 year after stopping rituximab, for instance. When you see the reoccurrence, the increase of CD19, you can stop the treatment with cotrimoxazole, but before that, never stop. We have seen some patients who have developed the side effect, pneumocystosis, 6 months after stopping immunosuppressant because they were still immunocompromised. Do not forget, of course, prophylaxis against tuberculosis. Tuberculosis has not disappeared, and this side effect is described very regularly. Fungal infections, of course, but we do not recommend a systematic prophylaxis with antifungal drugs in patients who have an autoimmune disease treated with immunosuppressants and steroids. Why? There is no study showing the interest of antifungal treatment, which are not also without side effects. And it has been the efficacy of antifungal as a prophylactic treatment has been demonstrated only in patients who had leukemia and who experienced bone marrow transplant, which is not the case of our patients. But for instance, we can discuss this prophylactic treatment with antifungal treatment in patients, for instance, with scleroderma and bone marrow transplant. Why not? But in others, certainly not. There is no systematic prophylaxis for viral infections, unfortunately. Here it is, I come back on the past. It is a study on H1N1 production of antibodies. And when you look at these season flu vaccines, you see that all patients have antibodies after season flu vaccine, except the group of patients receiving biotherapy who do not produce initially antibodies, very few 3 weeks after, and some after 9 weeks. And when they received the new vaccine against H1N1, of course, they had no antibody because there was no memory of this vaccine, of this virus. And unfortunately, they do not develop antibodies. And it was the same case with anti-COVID vaccine. Patients who have received biotherapies, rituximab, anti-TNF, anti-IL-17, and so on, have a high difficulty to develop antibodies to fight against the virus. Is why we have now some other policies. The COVID-19, we should make something with the vaccination in these patients who are depleted in CD19. Here it is another study very recently produced showing with rituximab and ocrelizumab. Ocrelizumab is used only for multiple sclerosis, and they inhibit the antibody production after vaccination. And it is what we have observed in the past and that everybody observed. Vaccines are not effective when patients have a very strong immunosuppressant. And the production of the antibody is very long to control. Here you have the comparison with the control and ocrelizumab. We choose that against flu, it is not really a good response. But now we have also some drugs. Here it is the same study in multiple sclerosis. Most patients with multiple sclerosis treated with ocrelizumab or rituximab unfortunately stayed alive, but they had 7 deaths on 435 patients, and infected patients could have an antiviral T-cell response, but may not generate antibodies. It is, I think, a very important sentence, because when we evaluate our patient with antibody production, we see that they do not have antibodies, but maybe they have a T-cell response. We don't know that. We have no information. It's very difficult to evaluate and to measure. But certainly it exists. And it explains also why there is a mortality, but maybe that the mortality would have been higher if this antiviral T-cell response did not happen. What to do now for our patients with COVID-19 and the prevention with COVID-19? Of course, mask, hydroalcoholic gel, everybody knows that. Vaccination of the patients and family. Family is very important, more than the patients. In immunocompromised patients, now we propose Evusheld, which is effective for Omicron. And we start to treat patients with Paxlovid, 5 days treatment. There is a lot of interactions, which is really a concern. I think that new drug will happen, but when we have a patient who have received a lot of immunosuppressant, who is at risk to develop a very severe disease, COVID disease, we treat the patients after contamination with Paxlovid, and prophylactically, we give them Evusheld, which is quite effective. Prophylaxis of infection should follow the recommendation established to treat secondary immune deficiency. I would like also to show you these slides, because there is a large prescription of IVIG, which is certainly not recommended. We know that patients should be treated when they have the severe infections, when the infections recurred, and when there is a resistance to antibiotics. It's more easy to control the bacterial infection than the viral infections. And for IVIG, we propose this treatment with some parsimony, and we do not give this treatment systematically to many patients. The recommendations have been published by many groups, including ours, and it is a summary of some of these recommendations: cotrimoxazole, anti-TB drugs, vaccination, IVIG, not systematically, except in hypogamma-globulinic patients, following the recommendation established for secondary immune deficiency management, and vaccinations against SARS-CoV-2 compulsory. I thank you very much for your attention.